camera itself was, but it was weird that it was a different focus through the lens because it's
yeah, I thought it was good.
I always see people doing
it's just looking at the image.
even if the lens is off.
So we both what side of it? It's like you just vision.
That's gotta feel weird. Video is done.
That was the first time to look at
Well, it's just my population. That's why I asked. So we're waiting on the corner.
There we go. Well, it wasn't actually I'm sure that the federal dollars are frauded in some way, but not specific. I'm yeah, I mean, it's a hard time. I would say April.
Names on the seats.
Yeah.
Good morning, everyone. Welcome to the Bipartisan Policy Center. I'm Bill Hoagland, a Senior Vice President here at BPC. I have the pleasure of working with our health team on issues that confront policymakers, beginning with the federal budget to insurance market stabilization to payment and delivery system reform. Our health care policy work here falls under the leadership of two former Majority Leaders of the United States Senate, Majority Leader Tom Daschle, and my last boss on Capitol Hill, Dr. Bill Frist. With their guidance, we labor to find consensus where we can on bipartisan proposals that advance policies to improve the health and well-being of our population, while, of course, controlling cost. But the first of its kind study we are releasing today is a little different than our previous work. It goes directly to the question of how $11 billion in appropriated 2017 and 2018 monies have been spent, how to address one of the most destructive, devastating public health issues that individuals and families are facing today, the opioid epidemic. The staff here, because I endlessly pressure them on this, they'll tell you that my reading list last year began with Dreamland, followed by Dope Sick, and ended with Evicted. Very challenging books. If anybody's read any of these, you know how destructive this epidemic has been to families and communities, and quite frankly, to our economy. But it's one thing to read about this epidemic, and it's another to witness its effects firsthand. And I can attest to harm it has caused. I come from an area of the country that my family's still there, that has seen and experienced firsthand and suffered from this scourge. But before I turn this over to our BPC Chief Medical Advisor, Dr. Anand Parak, I'm going to have him introduce Senator Shaheen, then he'll come back and he will summarize the report since the senator's on a tight schedule. I want to simply note that BPC has been focused on this issue for some time. In early 2017, our bipartisan Governor's Council, former Governors Beebe of Arkansas, Beshear of Kentucky, Douglas of Vermont, Gregoire of Washington, and Lingo of Hawaii, we outlined a set of recommendations for the President Trump's Opioid Crisis Commission, focusing on supply, treatment, and stigma. Later, working with a bipartisan group of senators, Senator Warner, Perdue, Manchin, and Tillis, we issued a paper focused on the epidemic in Appalachia. Also, as part of our early childhood initiative, we have advanced recommendations on the impact of substance abuse disorders on young children and families. Many of our recommendations, we are proud to say, made it into the final opioid legislation, Senator, but studies and policies, recommendations do little to combat this healthcare problem unless the resources are there to carry them out on a sustainable period. And the latest research I'm struck from the Harvard Medical School shows that it takes the typical opioid addicted user 8 years, and 4 or 5 treatment attempts to achieve remission for just 1 single year. The issue, sadly, is not going away anytime soon. Thus, the reason we undertook this task to at least determine how the $11 billion has been spent and allocated these last 2 years. So without further ado, and let me say it up front here, with special thanks to Anand Parak, Tim Schwope, Morgan Bailey, Regina LaBelle, Caprice Cafaro, Joanne Donaldson, and state officials, some of them represented here today, from Arizona, Louisiana, New Hampshire, Ohio, and Tennessee. They all contributed to this report. Anand will introduce the senator, and then he will come back and provide a brief overview of our results today. So, Anand. Well,
good morning, everyone, and great to see all of you today. And I think this is a
hopefully a pretty important and useful report that we'll be talking about for the next 90 minutes. But at this time, I think we're very pleased to welcome Senator Jeanne Shaheen to BPC today. And Senator Shaheen, as many of you know, has represented the state of New Hampshire in the United States Senate since 2009 and is known for her common sense leadership, hard work, and dedication to improving the lives of the middle class. She's been a champion of many issues, including economic empowerment, energy efficiency, national security, and fiscal responsibility. Senator Shaheen also served as governor of New Hampshire from 1997 to 2003, and also previously served as a director of Harvard University's Institute of Politics at the Kennedy School of Government. Senator Shaheen has been a vocal advocate for federal funding support to tackle the opioid epidemic since 2015, and was heavily involved in securing resources as part of the 21st Century Cures Act. She was also instrumental in negotiations to secure opioid use disorder treatment dollars in the 2018 and 2019 appropriations bills. Important for New Hampshire and other smaller states with high opioid overdose death rates, she negotiated changes to funding formulas to ensure that the hardest hit states receive the resources they need to promote treatment and recovery. We're thrilled that she's joined us today to talk about this critical public health issue that is also central to economic opportunity and well-being of this country. Senator?
Well, thank you very much, Dr. Park, for that very nice introduction, and thank you to Bill Hoagland, and to all of you for being here. A special thanks to the Bipartisan Policy Center, because this really is a bipartisan issue, and if we're going to continue to make progress on it, we've got to have Democrats and Republicans and unaffiliated people on all sides of the political spectrum who are working together. That's how we got the resources, the significant resources over the last couple of years, and how we're going to continue to make progress. Bill, I thought you said it very well when you talked about how do you get your arms around this epidemic and the impact that it's had. I think about that a lot because the statistics don't really explain the human tragedies that are involved in the opioid epidemic. It's had such devastating effects on the lives of so many people. If you go anywhere in New Hampshire, you will talk to someone who knows someone. If it's not their immediate family, it's friends, it's someone they know who has been affected by this epidemic. And it's interesting because there is, I think, a perception that where people have been affected by opioids, by substance misuse, it's because they are in communities that have been devastated economically. It's because they come from families where they haven't had family support. It's because there's got to be something wrong that there are individuals who have been affected. Well, I'm here to tell you, and I'm sure most of you in this room know, that that is absolutely not the case. That, in fact, one of the challenges I think we've had as we've tried to address this epidemic is that we've got to get people past thinking that this is a moral failing on the part of individuals and understanding that there are a lot of reasons why people find themselves with a substance misuse disorder. New Hampshire is economically very prosperous. We have some pockets of poverty in rural areas, but we don't have any big inner cities. Our average annual income has been in the top 10 in the country for decades now. We have a very higher than the usual number of people who have graduate degrees. So put aside any stereotype you may have about who has a problem with substance use disorders. New Hampshire has had the second highest opioid overdose death rate in 2016 and for several years. We are finally beginning to make some progress on that, but we're seeing special impact from fentanyl, which has really affected so many people who have been addicted because of pain medication, who have gotten into opioids, and then because fentanyl is included, it's even worse. Back in 2014, then Senator Kelly Ayotte and I did a hearing in New Hampshire on the opioid epidemic. We've been sadly at the cutting edge of what's going on for a very long time. And I will never forget the father who lost his daughter to the epidemic, Doug Griffin, who came in and talked about his daughter Courtney, who was 20 when she overdosed. She had gone in for treatment 2 months earlier, and she'd been turned away because her insurance company said they wouldn't cover the $12,000 to put her in inpatient treatment. She was supposed to go into treatment the following day when she overdosed. And I remember Doug testifying. He said, you know, when this was going on, when we were dealing with Courtney, we didn't want anybody to know. We were embarrassed. We didn't want our neighbors to know. We didn't reach out to for help. He said that was absolutely the wrong approach. He's now engaged in talking to people all over New Hampshire and the country about the importance of letting people know that substance misuse is a chronic illness, and we've got to treat it like a chronic illness. I thought the point about 8 years, 8 times, or multiple times in treatment to get 1 year of remission is a really important number to remember, because we've got to look at this not as a one-time treatment and then people are cured. We've got to understand that we've got to provide support for people for a very long time. One of the unfortunate things we've also seen in New Hampshire is that there's been a significant increase in other kinds of diseases. Viral hepatitis infections are resulting from intravenous drug use, and we've had one of our biggest hospitals talk about the ethical concerns around providing treatment and replacing organs for people who have been using substances, misusing substances, and the kinds of ethical questions it raises about how we use our healthcare dollars. I think perhaps the most important result that we're seeing today, and important because we're looking at future generations, is the impact on the next generation, the kids who are in homes where there is substance misuse, whose parents can no longer function because of that, the grandparents who have taken over. Between 2012 and 2016, the number of New Hampshire foster care placements related to parental substance misuse doubled. My husband and I have friends. He's an attorney, his wife's in real estate. They have their 3 grandchildren, and I won't forget what he said to me. He said, you know, I hope I can live to be 80 so I get the youngest one out of college, or out of high school. That's what families are struggling with in New Hampshire. And what we've seen from the action now in Congress is that we are finally beginning to get the resources that communities, that families, that states need in order to fight this epidemic. As you know, in 2016, we passed the 21st Century Cures Act, providing $1 billion to states over the course of 2017 and 2018. And again, this happened because of bipartisan agreement, people coming together and saying, you know, this is not just a problem in New Hampshire, it's a problem in Ohio, it's a problem in West Virginia, it's a problem across the country, and what can we do to try and help struggling communities? We were also able to provide $6 billion across all of government for opioid response for 2018 and 19, and $1 billion in additional funding for states to help increase opioid treatment. And one of the things that I'm most proud of is that we were able to get agreement to set aside some of those dollars, 15% of those dollars, to help states like New Hampshire and West Virginia that are hardest hit, the smallest states that haven't gotten the resources we need to help deal with this epidemic. So we went from 3 million, about 3 million, in state opioid response funding in 2017 to now almost $24 million in 2018 and 2019. So significant help. And as part of that, the state's been able to use those dollars to help set up a hub and spoke treatment plan so that everyone in the state should be within an hour of being able to get treatment. And just last week we found out that we got an additional $12 million because all of those dollars now are subject to the 15% set aside for small states. Now, we're still in the early days of getting those dollars out, but we know a couple of things about what works. First of all, what has probably been the most significant difference to help people who have substance use disorders has been the expansion of Medicaid, because people now can get treatment. So we're not going to have any more Courtney Griffiths who go in and she's going to be turned away because she doesn't have coverage to get treatment. We know that medication-assisted treatment works to help people. We need more people to be able to provide that treatment, more doctors. We made some changes in the last package in the Congress to help address that, to make sure that doctors could treat more patients, to provide additional help through nurse practitioners and physician's assistants, through a pilot program to see how that works. So we're able to provide more help for people in ways that we know works. We're also able to provide more funding for recovery centers. We have a lot of recovery centers with peer counselors to provide support, ongoing support for people. We know that there are programs that help pregnant mothers so that we can make sure those kids are born who may have neonatal abstinence syndrome, can be treated immediately or can be born without being affected. One of the Dartmouth-Hitchcock, and they're represented here in the room today, so they have a really wonderful program called Moms in Recovery. And one of the things that I was really impressed by was the cuddling protocol that they have for moms. I just like the name, you know. But because one of the things that we've learned is that what works for those babies is that if they're able to be cuddled by their mother, by an adult, and that is done over a period of time, that helps reduce the impact of the substance that is in their systems. We had a hearing a couple of weeks ago in the Appropriations Subcommittee, Help Appropriations Subcommittee, and we heard from people who are addressing the opioid epidemic from across the country. We had someone there from New Hampshire, Dr. Daisy Pierce, who runs our Lakes Region Recovery Center. We had the person who runs the program in Vermont, the person who runs the program in Missouri. And one of the questions that I asked everyone was, what happens if these federal dollars go away? Now, Daisy Pierce's response was, well, I'm going to have to go back to bake sales to try and fund our recovery center. But several of the people were probably even more blunt than that, and they said, people will die. If we don't continue to provide these resources to communities, to states, to families who need help, people will die. And so that's why the report that you're doing, that this bipartisan effort to continue the help that we're providing through congressional funding is so important, because we've got to continue to provide those resources to make sure we stay ahead of this epidemic, that we do make progress. In New Hampshire, we saw overdose deaths down by about 8% last year. So slow progress, but progress nonetheless. And we know that when communities work together, law enforcement, the medical community, the education community, and treatment providers, that's when we begin to make progress. One of the things that I think has been most important in New Hampshire was that law enforcement recognized very early that we were not going to jail our way out of this epidemic, And the best way we could help people is to make sure they got the treatment that they needed. So we've got police departments like the Laconia Police Department who have an officer dedicated just to making that connection between people with substance use disorders and the treatment community. Now this new hub and spoke program that you're going to hear about a little later in the panel discussion is going to be able to do that across the state. So we have lots of room to hope. There's lots of reason to believe that we can get ahead of this epidemic, that we can make progress, but it's going to take working together, it's going to take a concerted effort, and it's going to take continuing, not stopping, until we make real progress. So again, thank you for this opportunity. Thank you all for being here and for the work that you're doing to help us address this epidemic.
Sorry, I can't stay. That way, wrong way.
Well, I want to thank the Senator once again for her commitment, her leadership, and her insights today. This is certainly a bipartisan issue and a national issue, so we appreciate her being here today. And again, we'll be hearing from Senator Portman a little bit later. So to set the stage for today's discussion, I want to provide just a few high-level summary points about the report being released today. Hopefully you all have received a copy of that. So the premise is, while the federal government, in particular Congress, has stepped up its efforts over the last several years by appropriating resources to fight the opioid epidemic, no one has previously comprehensively looked at what these dollars are being used for and where they are going. And so for the last 6 months, BPC examined fiscal year 2017 and 2018 federal appropriations by reviewing congressional appropriations language, departmental and agency documents, and federal spending databases, as well as speaking with federal budget officials. We also took a look at how 5 specific states, Arizona, Louisiana, Ohio, New Hampshire, and Tennessee, politically and geographically diverse, but as a whole, a group that has a higher overdose rate than the national average, how these states were spending their dollars to support the front line of the epidemic. And as Bill mentioned, we're thankful to all the state officials who we spoke with and met with as part of this effort. So what did we find? Well, through this analysis, we identified 57 different federal grant programs across 5 executive branch departments and the White House Office of National Drug Control Policy that either entirely or significantly support programs that seek to end the opioid epidemic. These programs span the continuum of care, so prevention, treatment and recovery, research, criminal justice, law enforcement, and interdiction. The grants cumulatively accounted for $3.3 billion in fiscal year 2017 and $7.4 billion in fiscal year 2018. Between these 2 years, funding specifically targeted for treatment and recovery increased by $1.5 billion, from $600 million to $2.1 billion, a testament to the urgent need to reduce overdose deaths. Though the report did not focus on mandatory spending, it does acknowledge the critical role of both Medicaid and Medicare, in particular Medicaid, in supporting treatment of opioid use disorder. From the state analysis, there are 2 key findings. Number 1, federal opioid funding in these states is generally flowing to counties with the highest number of drug overdose deaths. That's a positive finding. Number 2, many rural counties seem to receive lower levels of per capita funding, although some of these counties had pretty high drug overdose death rates. And that points to the continued need to ensure that areas such as rural America, which have less workforce capacity and treatment infrastructure, are a point of continued emphasis. Based on BPC's federal and state analysis, the report recommends that federal funding must be, number 1, sustainable, number 2, flexible, and number 3, coordinated. First, while federal funding for treatment and prevention of opioid use disorder is critical, the epidemic is part of a larger problem of addiction in the United States. As Senator Shaheen mentioned, providing one-time funding is treating addiction, or in this case, opioid use disorder, as if it's an acute condition instead of a chronic condition. Funding must be provided with a longer time horizon rather than in annual budget cycles. Second, federal funds going to states must be flexible enough to allow states to address all types of substance use disorders, including the emerging problem of methamphetamine abuse. Drug trends morph over time. We've seen this with the opioid epidemic. What began in the 1990s with prescription opioids has evolved into an epidemic involving heroin and now illicit fentanyl. And lastly, there must be greater coordination of funding at the federal level. With 57 different funding streams going to states, without federal coordination, it's very difficult to expect optimal state coordination. The unintended silos created by numerous funding sources requires the federal government to provide oversight, greater oversight and coordination to help states tackle this problem. We agree with the President's Commission on Combating Drug Addiction and the Opioid Crisis, which called on the administration to provide the Office of National Drug Control Policy in the White House with a greater role in coordinating the federal response. It is too soon to evaluate whether federal funds are entirely investing in evidence-based treatment programs, such as medication-assisted treatment, and are most importantly leading to the desired health outcomes. Evaluation of outcome measures will be critical moving forward. However, transparency is the first step in understanding whether the federal government's role in tackling the opioid crisis is effective and ensuring that current resources are being properly spent. That's the goal of today's report, providing much-needed transparency. So I'm very honored now to ask our panel to come up to the stage. We have a great panel. We have Regina LaBelle, who will be moderating this panel discussion. Regina is a consultant at the Bipartisan Policy Center, has been instrumental in all of the activities Bill mentioned over the last several years that BPC has been engaged in on this topic. She's a former chief of staff at the White House Office of National Drug Control Policy and is currently a senior scholar at Georgetown University. So Regina will be introducing our panelists. Regina, panel, thank you.
Thanks and good morning. What I'll do is introduce each panel in turn and then have them make a few comments about their role in addressing the opioid epidemic, and then we'll have a series of questions and then also open it up for questions from the audience. So I'll first start with Liz Henrich. I pronounced that correctly.
You did.
Is an associate CEO of the Ohio Association of County Behavioral Health Authorities and represents Ohio's alcohol, drug addiction, and mental health boards. Liz directs the association's legislative policy and communications activities and has been with the association since the fall of 2006, so knows these issues inside and out. She previously worked in Montana for the Independent Insurance Agents and graduated from Carroll College in Helena, Montana, and holds a master's degree in public policy and management from The Ohio State University.
Very good.
To her left is Hamie Tuerson, who is with the National Governors Association Center for Best Practices Health Division, where she oversees health division projects for a vast array of issues, including Medicaid transformation and coverage, Medicaid data systems, opioids, behavioral health, and social determinants. And previously, she worked for the Office of General Counsel at USGAO and was in private practice as a health policy attorney. She has a JD and master's degree from George Washington University and an undergraduate degree from the University of Pennsylvania. And then to her left is Patrick Tufts, who is the chairman of the New Hampshire Governor's Commission on Alcohol and Drug Abuse Prevention, Intervention, and Treatment. And since 2010, he has been the president and CEO of Granite United Way. Granite United Way raises almost $9 million annually and aids about 685 charities and 350,000 people every year. Patrick has a master's in social work and administration from the University of New Hampshire and received his undergraduate degree from Missouri State. Thank you. Again, welcome, and I'd ask, perhaps we'll start with you, Liz, if you tell us a little bit about the role that you play in addressing the opioid epidemic in Ohio.
Sure. I'm going to start that with a little bit of a background of what Ohio's ATOM boards are. We have a strong county-based system in Ohio. We've got 88 counties, and we have 51 alcohol, drug addiction, and mental health boards that are units of political, they're a local subdivision. They're charged with planning for, evaluating, developing, and funding a local system of care for both mental health and addiction services. We represent them at the state level, doing a lot of work with our Department of Mental Health and Addiction Services, our state legislators, our congressional officers as well, sort of at that advocacy level. We also provide a fair bit of training and technical assistance to the local boards that are working to make sure that those local systems are in place for individuals and families. Ohio is a very diverse state, both in population and in geography. We've got 88 counties. We have counties that have major metropolitan areas. We also have very rural Appalachian communities. So our structure needs to account for communities of very different size, geography. The needs for transportation are different depending on where you are. And all of this overlays the complexities we have with the clients that we're trying to serve in our communities, whether they have a mental illness, an addiction, or both. So that's a little bit of what we do.
Great, thanks.
Hi, everyone. I'm really pleased to be here. We have played at the National Governors Association a significant role in our work on opioid and addiction more broadly. Since 2012, we have really been working with governors. It's their top priority, unfortunately, and it continues to be. Two things I just wanted to share with you, and that's why I'm so pleased that Bipartisan Policy Center is focusing on the state's role, because they have been leading the way for quite a number of years now on this epidemic. There's two roles that we have played that I just wanted to just let you know about. One is through our, we have an NJ advocacy side where we really represent all of the governors with Congress and the administration. And in that role, if you can imagine how hard it is to get a set of recommendations across all governors on a topic like healthcare, but this is certainly one that has been a topic that has complete bipartisan support, I think, like the senator mentioned. And we have sent recommendations to Congress and administration on this issue. And, the SUPPORT Act, for example, had a number of those incorporated in it, but we continue to advocate on that. Where I sit in the Center for Best Practices, we really play the role of sharing best practices with states. And, no one state has solved this, but they learn a lot from one another. And it really is important on this epidemic that continues to evolve and change. And there's a number of areas where we've really worked intensely with states just over the last 2 years. That includes things like facilitating information sharing, data frameworks between state and local government, reducing the number of cases of neonatal abstinence syndrome, expanding access to treatment for opioid use disorder in rural areas, addressing how states can use their emergency powers to address the opioid epidemic, addressing heroin and illicit fentanyl use, which has also cropped up in many states. And another area that we really are spending a lot of time are in increasing Medicaid-assisted treatment to justice-involved populations, and really how to connect them to services upon reentry. So really looking forward to the conversation, really happy to be here. So,
Patrick.
Again, my name is Patrick Tufts, and my day job is I'm the president and CEO of our state's largest United Way, and I've been doing that for about 20 years. And I would say over the last couple of years, the issues of addiction, especially the opioid crisis that's hit our state, has really become front and center for my private philanthropy, which raises and invests money in programs all across our state, from the most rural part of our state all the way down to the more metropolitan areas. Most recently, I was appointed as the chairman of the Governor's Commission on Alcohol and Other Drugs, which really is a legislated body that was created about 20 years ago to advise and provide counsel to the governor, the state courts, and to our legislature on the investment, advocacy, and coordination of all sources of funds to address prevention, treatment, and recovery services in our state.
Great, thanks. So I want to talk, the report really addresses federal funding that goes to the states. Tell us a little bit about how your state, Patrick, you're intimately involved in this. How is your state organized to kind of funnel these funds to where they should go? And Hammy, if you can just speak to it broadly from the NGA perspective.
Want to go broad first?
No, go ahead.
So first, the senator stole all my thunder. So she's so involved, and we really are blessed in New Hampshire to have a great delegation and a great governor who's advocated so much on behalf of New Hampshire citizens. To the senator's point, what we're able to do is build a system up where no system existed. We are a rural state, and we were completely decentralized in how we were addressing the addiction issue in our state. So what we've been able to do is build a hub and spoke system where no one in the state of New Hampshire has to travel more than an hour to get the case management, clinical assessment, MAT services that they so desperately need. Prior to that, people were traveling up to 4 or 5 hours to get those same services, being disconnected from their communities and their support networks, and it was really proving to be problematic for our state. So we were able to take the initial $23 million that we were awarded through the federal government and create this, we've called it localized as 9 doorways. And we were able to put them in some of our strongest partners all across our state, which in many cases are the hospital institutions in the local community. That helps us with sustainability. It helps us with services all being in one place. And to date, in 2 months, we've served nearly 1,000 people through these 9 doorways in a state with 1.3 million people. So we've really been able to take off very strongly in people's local communities in a very supportive way to assign case management to people as they come in and to coordinate those services with the spokes out in the local community, which really for us is very innovative and basically unheard of.
Yeah, it's wonderful. And from the National Governors Association perspective, so we've worked with many, many states on this topic and how they're organized and what works, what doesn't work as well. And one of the things we really found that's been most effective is when the governor in the state can lead the charge and really help to centralize all the different parts of the state that are involved. And because it really is a diverse group, just within NGA, you know, yes, I lead the health division, but we partner with our Homeland Security and Public Safety division, for example, on all of our opioid work, because public safety and law enforcement is so important. So at the state level, there's even more, you know, agencies, counties, really a diverse set of stakeholders that really have to come together to address and coordinate their response. So what we've really seen is the centralized framework where there is, you know, a drug czar or a task force where they're all linked together has really been one of the key elements to really making a difference on this. And that would include, you know, public safety folks, health folks, human services with the foster care system, the housing folks, transportation folks. So, you know, a really wide array. And really, I do think the federal funding has enabled some of that as well to really create that structure in some states and really been able to sort of mobilize the action.
Great.
So.
And Liz, you're the county government viewpoint on this. If you could tell us a little bit about organizationally in Ohio, kind of at the state level, and then how that works with, interacts with your organizational structure.
Sure, and I think to Hamy's point, there is that leadership at the governor's level within Ohio. So our cabinet agencies are working together. They're trying to identify where those fund sources are being plugged into communities. We then, in most communities, have that replicated at the county level. So that you've got county transportation, human services, alcohol, drug addiction, mental health, criminal justice, law enforcement, the judiciary, all together around tables in those communities, trying to figure out how to take these fund sources that are varied and come with different requirements and use those to deliver services in the community. Because we want to make sure that regardless of where somebody presents, we can connect them into the network and those services are tied together there. We also want to make sure that we aren't, you know, using different fund sources to build parallel systems. We want to make sure that we're effectively using those fund sources so that we can build the best systems in our communities. And that takes coordination sort of at every level. We've got local property tax dollars, state general revenue dollars, and federal funds that are getting put into these systems in our communities. These are all taxpayer dollars. We want to be accountable to our taxpayers, but we need to make sure that we can coordinate and efficiently use those in communities as well.
That's great. Thanks. So Senator Shaheen mentioned this, and I recall having seen that hearing where people said, you know, we'd have to have a bake sale. It would have really big implications for our communities. If you could tell us a little bit or expand a little bit on that, how important is federal government funding for your state's opioid response? And then secondary to that, Tell us about some success stories. So, you know, there are some states that are doing some great things, innovative things. So tell us a little bit about how important it is, the federal funding, and brag a little bit about what your state is doing. So you want to start?
Sure. I mean, I think that this investment that we've seen over the last couple of years has really been what's helped us start to turn the corner on this crisis. Our 2018 numbers are preliminary at this point, but they're looking better than our 2017 overdose numbers looked. This is because we've infused resources into communities to bring up services that we knew we needed, but didn't have the resources to fund. It also has changed the conversation around addiction. We're not, you know, talking quite as much about the shame and stigma associated with addiction. It still exists, don't get me wrong, but we've prioritized it at such a level throughout government that all of a sudden there's more focus on making sure that individuals have access to the care that they need. We are also a Medicaid expansion state, so that has allowed us to use some of these resources to wrap services around those core treatment services. We've got focus on peer recovery supporters in many communities. Many of our communities stood up what we call quick response teams that are entities with, you know, law enforcement, a counselor, social worker, and a peer that go out to an individual following an overdose and try to engage them in treatment. We know that if we can engage someone in treatment when they're ready, we have a much better chance of keeping them for 60, 90, 180 days and helping to sustain that recovery. We also have a really pretty impressive model that I just got some numbers this morning where we have ED case managers that are working in the emergency department, engaging individuals. We're inducting onto MAT in the emergency department, but that case manager is traveling with that person to make sure they have the right linkages into care. When we tie that together with a peer supporter, we've got some sites that are showing 78% success rates in individuals engaging in treatment following an overdose. Those are pretty good signs for us to say we can take these models and we can spread them across our state and then into other states as well to try and build on the successes. We don't all need to build something brand new. We can figure out what we can beg, borrow, and steal from one another to move things forward.
Great, thanks. Amy, you want to give some examples?
Sure, sure. And I love the term beg, borrow, and steal. We use that all the time. It's absolutely right. So there's a couple of examples that we found where states are focusing on, for example, MAT and corrections. So really identifying how to use the federal funding to better address expanding access to MAT, not just when the folks are incarcerated, but also when they're coming out into reentry. So one state, for example, implemented a comprehensive OUD, SUD treatment program in county jails. So one example, very concrete, of what they're doing. Recovery housing and supportive employment. We've heard a lot about that, and I feel like that's how this crisis is evolving, right? First we're focusing on the number of deaths and how do we address the number of deaths, and now we're thinking holistically, okay, like what are the other pieces in this person's life that's really going to help them actually try to recover? So there's a couple of examples, especially in the Medicaid expansion states, where they have been investing some of these dollars in trying to help get folks that have OUD with access to recovery housing. So that has been, I think, a really interesting movement. Sustainable capacity. So, you know, I think that the Senator's comments were so on point about how this needs to be sustained over a period of time, and we really need to build capacity to try to really fully address it. There are certain areas in states where they just don't have a lot of capacity. So there are some states that have tried to be really creative, and you know, they're not really just addressing opioid, right? They're addressing other substances with other addiction that are maybe related or maybe not related. And so how do we really build a sustainable infrastructure and use those federal dollars to do so? And so one state, for example, they were like, we are going to put FTEs in our community mental health clinics across the state who really understand addiction, because those clinics are not equipped otherwise to really effectively deal with this population. And that is their, you know, one step forward on how to really try to expand the workforce and the expertise in areas that are hard to reach. I think there are some states that are using the money, especially from the Centers for Disease Control and Prevention, on data infrastructure. So part of understanding how to address, you know, areas in your state where you have the most need is understanding the data and what's flowing from the data, and not just at the state level, you know, linking to the county data, which is a huge challenge. Yes, and then below that is even more challenging. And so really making those investments to understand those different layers of data and how you can pull out what you need to understand to then better target your response and more, I think, more effectively and rapidly respond to what the needs are is really important. And finally, I did want to mention infectious disease, because I forgot to mention it earlier. We've been spending a lot of time with states on projects trying to address infectious disease, which has been, I think, further expanded, unfortunately, with opioid use disorder and other addiction, with Hep C and HIV, for example. And so states have been using some of these dollars to invest in things like harm reduction and syringe exchange programs to really try to address, can we really slow down the transmission of these infectious disease to these different populations? There's just a couple of examples.
Great, thanks.
Yeah.
Patrick?
You know, in a small state, and the senator referenced this, you know, we've turned drug overdose deaths, we've reduced it for the first time in 5 years. And that's approximately 50 people, 50 lives that we've saved. That's 50 sons, daughters, parents. That's really important in our small state, and we feel it very genuinely. What we've been able to do is stand up, you know, a system, again, that didn't exist before. And we wouldn't have created a hub and spoke or doorways model in the state of New Hampshire without this federal money. It just wouldn't have happened. So we've created a system of care. We've created case management. We've created the really critically important having a peer support worker or, you know, somebody in the emergency room immediately during an overdose. We've been able to make those connections back to somebody's local community. What we're finding in New Hampshire is that our response is very holistic. By tying the hub and spoke model to our state's 2-in-1 system, we're really starting to identify the myriad of needs that people come to this situation in. They don't just need help with their addiction. There are behavioral health issues, there's poverty issues, there's homelessness issues, there's family problems. So we're really able to surround the client with a multitude of services right at that point that they ask for help. And what we're determining is that's critical. And by being able to do that in 9 different hubs all across our state, we're meeting people at that life or death moment, and we've saved 50 lives right out of the gate. You know, I can't reiterate this enough. Without the federal support, we don't have that system. One of the other things that we've been able to do is use the resources that we do have. In New Hampshire, you know, this crisis shouldn't have happened to New Hampshire. We're a wealthy, healthy state. Yeah. We're a small state. There's a lot of great things going on in New Hampshire. You know, this shouldn't have happened, but it did. And we lost 485, you know, New Hampshire residents to this last year. We're turning the corner on it. The commission that I run, we have approximately $10 million a year, which has never been enough. But we've been able, because of the federal funding, to pivot the funding that we have and do some of the things that we know we should have been doing. So we just doubled down on our investments in prevention and early childhood resiliency, right in our hardest hit communities, because we know that we need to be talking to young people and their families right now about this. So we just appropriated just under $3 million to that immediately, and that's going out in RFP right now to local programs. We're able to identify the connections in our spoke services and where we have enough local programming and where we don't. And we're learning a lot about the connection to homelessness and housing and the connection to sober housing and recovery and where those exist in our state and where they don't. And that's going to be the next pass for us, is building out those spokes locally all across our state. So, you know, to the original question, a lot of our success and a lot of the success that's yet to come is very, very dependent on this federal funding. Mm-hmm. And in a state like New Hampshire, we have no income tax, we have no sales tax. Without this funding, these solutions just aren't in place.
Yeah. Great. So we'll get to audience questions in a second. I have one last question for each of you. So if you look, as you look around the corner, you've kind of spoken to this a little bit, but what should federal policymakers know about the needs of your states and states generally? If you want to start.
Sure, I can start. I think it's important to know that whether we successfully turn the corner on the opioid crisis, we still have more work to do in our communities. We're seeing influxes of methamphetamine. We're seeing more use of cocaine. Alcohol continues to be a problem. This addiction crisis that we're facing right now is not going to go away quickly. It's not going to be an easy fix, and it's not going to be something that we're going to be able to probably say at any point, good work, we're all done. You know, we're going to keep battling this crisis, and I was talking to Hamey earlier about the fourth wave. Yes. You know, we're going to keep seeing this transition, so we can't let our foot off the gas right now because we're seeing some success. We're seeing success because we're building community networks of care that weren't there before. We're building partnerships that didn't exist so that we can address addiction in individuals prior to a crisis situation. We're keeping people alive with investments in things like naloxone so that they can engage in treatment, get back with their families, get into the workforce. I mean, all of those steps are going to continue for the individuals we're serving. So right now, we need to make sure that we keep moving forward. We need to do that with sustainable fund sources. We need to do that with some flexibility on how states can use those so that we can continue pushing resources into communities where those needs are.
Yeah. Thanks. I wholeheartedly agree. I was going to say the same thing, so I won't repeat that. So yes, yes, yes. A couple things I would add, and NJ has certainly actually gone out and recommended this to Congress and the administration, was improved coordination amongst the federal agencies. So a lot of different funding sources. I think this report was excellent and really needed to identify all the different sources that are out there from federal funding, but more coordination at the federal level I think, would be helpful to the states, and that's something that we've been continuing to promote. Data sharing. So I'm just going to keep, like, you know, knocking on that data door. Really need some improved data sharing capability. And, you know, there's things like 42 CFR Part 2 that, you know, really makes that challenging for states, as well as state laws underneath 42 Part 2. But really, without that piece, we're not going to be able to completely understand the evolving nature of the crisis. So I'm going to keep talking about data. The federal grant duration, that's one thing that we've talked about internally at NGA and have put in our recommendations. The 2-year cycle is very hard to manage for states. And I think, you know, Liz, all your points about the long curve of this crisis, what you're trying to do on infrastructure and sort of the amount of time that you need, you know, just purely from a state contracting perspective, number one, for example. Yes, there are funds that get extended, but it's really hard to plan when you're on that 2-year cycle. So really some more flexibility on the time frame I think is really important. And then I just have to say, you know, really thinking about opioid, the term opioid is what is getting the attention of Congress and folks around the country, and the funding is really dedicated to opioid with some flexibility. Really, I'm going to emphasize this point, making it more broadly to address addiction, I think, is what is needed, because there is absolutely this fourth wave, and really, we really need to think about across our country how we're really going to address that in the future years.
I agree with everything that was said. I think we're very consistent on that front. I would really, really make the plea for flexibility, because we are seeing more complex issues. Our hub and spoke system, we don't turn anybody away. And while we've had a terrible opioid crisis in our state, we still have issues with alcohol. We have growing issues with meth and cocaine, so we're seeing that. So we need the flexibility to be able to address that. I would also like us to really start to release and invest more in prevention. That's going to be critical in New Hampshire. We do have issues with addiction in our state, and we got to where we got for a reason. And we need to really double down and triple down on prevention and resiliency with young people, within our families, and make sure that those resources are there for more than just 2 years. And I think in our SOAR grant, we only had about $300,000 of the $23 million dedicated to prevention. We were very lucky in our state that we were able to use other sources, like Governor's Commission dollars, but we're not going to be able to do that forever. So that would be my plea, is some flexibility, and really, let's not forget about prevention.
Yeah. Great. So if I could open it up for questions, and I'd ask, because the panelists did not write the report, we're happy to answer any specific questions you might have, but please don't put them on the spot. Andrew, if you have a question, and then.
Good morning. Andrew Kessler. I represent a variety of treatment interests around the country. And the attention we've gotten from the federal government is great, but for decades, the federal government was not very involved in this process, and as a result, there wasn't a lot of oversight. There's a lot of fraud in the treatment industry. I know Ohio has been active in working on this, but can each of you speak to how your states are making sure that the money you're receiving are going to programs that are genuine, are using best practices, evidence-based practices, have professionals who are credentialed and so on, because we're very concerned that there's a lot of black eyes in our industry as a result of there not being a lot of oversight for years. So we want to make sure that given this one opportunity, we're doing it right. So can you speak to how your states are assuring that it's going to absolutely the most genuine best practices?
Well, I can go ahead and start there. You did mention Ohio's done some work in this space with some recent legislation that requires that any public fund that's used for addiction treatment is through a certified entity. So they've got to be certified by our State Department of Mental Health and Addiction Services and go through a series of criteria for what that means to make sure that they've got the right staff in place, that they're delivering services in that effective manner. There's also been a heavy focus in Ohio on evidence-based practices, and that is good in many communities. That's a struggle for some communities because of the workforce requirements and the fidelity measures and the cost, quite honestly, that comes from some of those evidence-based practices. So we're trying to figure out how to balance the desire to have good quality care delivered in our communities with the practicalities of some communities, the workforce struggles, what exists on the ground in communities as well. So I think it's an important point to make, and it's not an easy thing to do, but it is something that we need to all collectively continue to focus on.
Yeah, we struggled with that a little bit in New Hampshire, to be honest. As we geared up to address the opioid crisis, we had a lot of treatment providers that kind of came out of nowhere, and the regulations weren't in place, and we had some notable failures, to be honest. I think what we've done with this influx of federal funding is we went to very highly credible partners as our doorways. We went to our hospital systems first. We really tightened up our RFP process. Evidence-based best practice, track record, accountability have all been doubled and tripled, and I feel much better about where we are today than I did a year or two ago. I think it's fair to say in New Hampshire, this crisis caught us by surprise. We weren't prepared. So we had an early influx of a lot of providers that really didn't have their feet on the ground the way they needed to deal with billing issues and just honestly the evidence-based best practices that we have to have. So we've taken your feedback very serious in New Hampshire, and it's really improved our system.
And I think to add one more component to this that's important is not just that regulatory structure, that's critical, but also how we share information with individuals and families about what they need to know when they're trying to access treatment or help a loved one access treatment. It's not a well-known industry to the community at large. Those of us in this room may know what we're looking for if we're trying to direct someone into good treatment, but many of your families and friends, I'd argue they don't. And so they'll start with what they do know, which is something like they're going to search it online. And that doesn't always have the best path into high quality treatment. So it's something that I think we also need to work on. And it's hard to focus on things like how we share information and should we have a hotline or a website or what it is that we direct people to treatment, when on the other side we're trying to keep people alive to get them into treatment. When you prioritize resources, we need to find a way to make sure that that's balanced and there is that focus on client education and family education for accessing treatment.
Just one quick thing to add. In the Medicaid piece, there's a specific, I think, movement across all the states for institutions for mental disease waivers. So there's a lot of those new entities that are coming online, and I think that question has really been coming up across the states with these waivers in terms of, what facilities are going to be deemed IMDs, how are they going to get paid, and I do think because of the prevalence of Medicaid managed care, states are partnering with their managed care organizations to try to think about what are those networks and how should they really function in an effective way. So I just wanted to add that point.
Great, thanks. Here, I think there's a mic.
Yeah.
I'll wait this time for the mic.
Yeah.
A lot of the discussion today has been about increased coordination between federal agencies. What specific steps can federal agencies take in sort of another layer of specificity, adding what really specifically can we do to improve that coordination? What are the barriers that you're seeing from the lack of coordination, and how can we overcome those?
You want me to start? You want me to start? Okay. So I think the federal agencies are all playing a critical role. Agencies like the Department of Justice and the Centers for Disease Control and Prevention and SAMHSA, of course, who really are in control of the two big STR and SOR grants. From our perspective, and we work with each one of those agencies very effectively. CDC actually funds all of NGA's work on opioids. There isn't always the seamless coordination between those three agencies, just as one example, where you have two big funding sources from one, another big funding source from another, and then yet other funding sources from a third. And so thinking about how those overlap with one another, how can they complement one another, how should states be thinking about that, and having guidance from the federal agencies at the state level of how to think about those funding sources and how they can work with one another, I think would be helpful.
Thanks. Sure. You have a mic right here.
Amy, your points about data and data sharing are well received. I work with the SAS Institute out of North Carolina. I've done a lot of work with states, in particular North Carolina, Massachusetts, a handful of others. And if you haven't taken a look at the Chapter 55 legislation that the Commonwealth passed a few years ago, it has a lot of good examples of getting the right data sharing agreements in place between disparate agencies. So I would highly recommend that states take a look first at structuring your state so that they can share the data so that when the federal money comes in. A point and maybe a question also on flexibility. For too long, data and analytics have been treated more as an administrative function in how grant dollars are spent and not in the actual execution of the grant. I know there's some states that see some inflexibility around SAMHSA dollars in that vein, and I know Congress has moved more towards creating more flexibility, but are you seeing or hearing that also in the states that if they had a way to make the data more actionable without coloring outside of the lines, if you will, on a grant, that they would be more inclined to do so?
I'm happy to kick it off first. So we've seen the most use of funding for data through the CDC dollars. So states have been using the CDC dollars to really think about data infrastructure. We have heard less that they're using SOR and STR dollars. Now, that's not to say some states aren't doing that, but what we've heard from states is definitely coming from sort of the CDC line. And I will take it back to see if they had more access. I'm curious from your perspectives if that would be true.
I think it's from the Ohio perspective, and I'm not incredibly well versed in all the data, so I'm going to share at a pretty high level. Yeah. There is a lot of work going on right now to try and unpack who has what data and what are the barriers to sharing that data. So looking at models from other states would be something I think we'd be very interested in. We have a new governor that came into office and established what we're calling Recovery Ohio, which by executive order, he has a group that's sort of coordinating a series of recommendations for how we should address addiction in Ohio. They released their report just in the last couple of weeks, and one of the primary recommendations is we need to do a better job with the data we have. We have a robust county structure in place for human services, for law enforcement, for alcohol, drug addiction, and mental health, and I think sometimes our barriers with data may be artificial, but we don't know that. So we need to dive in a little deeper to figure out what is a real barrier and can we fix it versus nope, that's a hard line that we're going to have to figure out something else for. And right now that work is underway.
My colleagues are much better versed in this than I am. I'm a United Way guy, I know that what we're looking for, and I've really enjoyed working with our governor because our governor's background, he's an engineer. And we're looking at this and saying, we want to use data. We need evidence to determine what's working. I mean, there's lots of data out there, and people present data in lots of different ways. One of the things that we're doing by having this coordinated system of care and the ability to follow people through the various steps is to really identify what's working, what's not working, and honestly to put some accountability and performance metrics behind making sure the dollars go to the right place. And that for me has been very rewarding. I know it's rewarding to our governor, is we know we're not going to have unlimited resources moving forward, and we have to attach the resources to the people who are creating the impact that we need for those resources.
Yeah.
We have a question back here. Oh, there you are.
I think one of the positives to come from the opioid crisis is the fact that local governments have had to really repurpose and innovate to adapt to the lack of services. So I know, for example, in New Hampshire, y'all have in Manchester and Nashville, the Safe Stations program. Curious to know now that you are transitioning to a hub and spoke model, how's that current system going to either integrate or be sort of phased out in a way?
So the single largest entry point for the hub and spoke system is our Safe Stations model. And I don't know if people are familiar with that, but we were so overwhelmed by the opioid crisis that in Manchester, Nashville, and a few other communities, we opened up our firehouses for anyone battling addiction to walk in, immediately be triaged, and connected to a recovery organization. And we have multiple entry points into the hub and spoke model. People can call 211. They are referred by emergency rooms. They're referred by not-for-profits. What we've had to do is really integrate the Safe Station model with the hub and spoke model. What we're finding is the lack of support services and surround services in our more rural communities means that our more metropolitan areas like Nashville and Manchester, who have Safe Station programs, are still having people referred to them because of just the excellent service that they've been able to provide over the course of a couple of years. Just in Manchester alone, 5,000 people have walked through firehouses in the last 3 years to get service in a small state. So that coordination of what's working is critically important. The hub and spoke is not going to detract from Safe Stations. Safe Stations not going to detract from the hub and spoke. 211, our information and referral line, is not going to detract from others. We've got to coordinate these three really positive things and make sure that we're all on the same page.
Yeah. We have a question over here.
I wanted to thank you for talking about harm reduction and syringe services programs. I work with about 100 programs doing capacity building assistance. They've had a lot of trouble accessing any federal or state public funding, and I wanted to hear from you all about some of the successes and challenges that y'all have seen in your areas.
Yeah, I'm happy to kick it off. So, you know, we are just coming off a project where we highlighted Kentucky because they have established, I think, close to 50 syringe exchange sites across their state. And they were able to use different sources of funding. So state appropriations, but also some Medicaid dollars and some other federal dollars as well through the opioid crisis to really stand those up. And so we have had 5 states come and learn about what Kentucky is doing, and it wasn't just on the funding side, it was also on how to stand those up in communities, because that is challenging in and of itself as well. And it was amazing. They, you know, you probably have experience with this, you know, partnering with, like, you know, the local fire chief and the church and, you know, all those communities that really feel like, okay, yes, we want to do something for our community. So I think there is some creative ways to think about how to, you can't pay for the needles themselves, but for the services around it, you can find a lot of different ways to be creative about paying for it.
And I think we're experiencing some similar focus from communities of trying to figure out what can they learn from models that exist, what is, and I think as important as the financing is that community conversation that you have to have and how you approach that with your community to make sure that the understanding is that we're trying to engage people in treatment services, that we're trying to promote positive health, not that we're trying to promote use. And that's a complicated conversation for a lot of communities to have, and that is a challenge in many cases. But how you approach that can actually help decrease stigma in communities, can provide that educational platform for members of the community and promote the use of the services that can keep people alive and engage them in treatment.
Yeah.
I'd say the same thing. It's allowed us to avoid the flat nose in some communities. We've been able to have conversations about harm reduction and use examples from other states and other communities in our state as to why that can be a really effective tool in the toolbox.
I think we have a question back here. Yeah.
Thanks so much for a really interesting panel. I'm the Household Fellow with Dartmouth Hitchcock. And Patrick, welcome. It's nice to see you in DC, and thank you for everything that you're doing in New Hampshire. Dartmouth Hitchcock is very happy to be partnering with the state and part of the hub and spoke model to get treatment to the folks that need it most. I'm curious, though, as we support the most rural areas of New Hampshire, about workforce challenges in treatment and all levels of providers. And I'm wondering, you know, I know there's efforts in New Hampshire underway, but I think Hemi and from also Ohio, what you're seeing at the front lines as far as workforce to make sure that there's providers that can help our citizens in need.
Yeah.
If I can put some context on that, and I really do want to thank the Dartmouth-Hitchcock system. We're blessed to have that system in New Hampshire. They do the nights and weekends coverage for our hub and spoke system, so that doesn't put that burden of responsibility on each one of the hubs. One of the things that we've recognized, and it really was a bit of a shock to us, is we're having a hard time finding the professional staff to staff our hubs. It just is a real critical issue for us. It was on my notes, so thank you for mentioning it. We need some help, and I don't know if there's great ideas from other states, but this is a real issue for us. We have vacancies in our doorway and our hub programs that we need to get filled in order to really utilize these federal dollars and to save lives. Yeah. And that is a significant issue for our state. And we're looking for answers. We need to get these positions filled. We need to get people to choose these professions to go into and to incentivize it.
Yeah.
Yeah, I wish we could say we had a good answer, but I think we're experiencing a lot of the same struggles. And I think the conversation that's happening right now is, how do we go even further upstream? How do we have conversations in high schools, in college, to say that this is a career path for you, that this is a conversation that we can have? That does become a challenge when you then look at the caseloads, the trauma that individuals in the workforce experience, and how do we make sure that we're supported and paying a living wage to individuals that we're asking to do incredibly complex work in our communities. So that's the easy answer.
Yeah, and I would say, yes, kudos to you for raising this point. From our perspective, I don't think any one state has solved it. We did highlight New Mexico's Project ECHO model just for when you don't have enough capacity, and we had a number of states learn about that, and of course you have to stand that up and in a sustainable way. But I think this other piece about how to really create a career pathway is really important, and that is on our list of things to continue to tackle. So
not to open a can of worms, but one of the things I think we're going to have to explore in New Hampshire is the ability to do telemed.
Yep.
And I know you guys have looked at that, but we're going to have to figure that out. Where we can't get the bodies, we still have to get the service.
And Medicaid can pay for some of that. So
we can take one question, and then I'll.
I wonder if you could talk about any efforts that have been made to disaggregate tracing the funding by age group, and need to think about our adolescent and young adult population, since this is a pediatric onset disorder. And just wondering, because the adolescent system is so different, partners can be different, social influencers of health, recovery supports can be different. Could you talk a little bit about the adolescent and young adult population?
Specifically to the details of how whether or not the report was disaggregated, no, but I'm sure somebody from BPC can give you that information. To what is going on in communities, we've got some good work in Ohio related to recovery high schools and trying to build that support around the adolescent population. I will say that that's probably not as broad as many of us would like to see it, but it's burgeoning, it's developing in many of our communities. I think we also have to do a lot of work. It's not just that prevention conversation, it's engaging and breaking down barriers, because if we can get somebody into treatment earlier on, or even into an intervention type model, that's something that we should be looking at and figuring out how to engage. It's working with primary care practitioners, pediatricians, those that are having interaction with parents, kids, everybody who may be part of that family, and in trying to wrap that service around. We have a lot of incredibly complex youth cases in our state, and we don't, probably similar to every other state, we don't always have good answers for that. And that's a challenge we continue to face.
Again, I can't address the report, nor would I, but in regards to some of the things we've done in New Hampshire, we've been able to pivot with some of the local dollars that we have to support our drug-free communities, which are really grassroots, very, very focused on adolescent and school-age kids. A lot of those grants had reached their 10-year cycle with federal funding, so we've been able to backfill that. We've been able to make dollars available in a really grassroots way in New Hampshire, and those of us from New Hampshire is a grassroots state. I mean, we take the live free or die thing really serious. Yes. So we have to get local, and we have to get grassroots, and this commitment and focus on adolescents and young people is really what we're pivoting to and trying to take advantage of this opportunity.
Okay, we have a question back here.
Lots of good questions.
I haven't heard any mention of holistic medicine and outcome data for modalities such as acupuncture and diet. We have a lot of adulterated foods in our food supply in this country that people are told are safe, and some would argue they're chemicals paraded as food. And not everyone can afford organic food, but maybe looking at diet. And the research I've come across in government databases, one area shows that you can identify a child and family in need of intervention by the 3rd grade. But we don't necessarily act on that. We put money into standardized tests and we don't have counselors and nurses, adults for kids to talk to. And the state of Maryland in 1995 published a study comparing holistic and allopathic remedies for 6 common disorders. And in every category, the holistic outperformed the allopathic in terms of cost, benefits, efficacy, outcome, and side effects. So who's looking at these other types of therapies? It disturbs me that a condition or a problem created by a pharmaceutical is being addressed only by a pharmaceutical. Can someone comment on that, please?
So,
Comment. You want to go first?
well, I'm going to brag for a minute about something we did in New Hampshire. Our commission has multiple task forces, and one of our task forces is a treatment task force. And somebody had the foresight to invite in acupuncture experts. And we had a very thorough 90-minute educational session on the benefits and harm reduction related to acupuncture. And every one of the task force members went through a procedure. And then that task force recommended to the commission that we endorse acupuncture as a benefit in treatment. So we actually brought that rate to state government and have made acupuncture in particular something that we're sharing information on and has endorsed as a commission. And again, that really relates to our grassroots way of doing things. This is, you know, it came upstream, and it's something that honestly I didn't know enough about. So it's a good conversation that we had, and it's gone right to our State House.
And I would say the NJ actually has spent the last 6 months thinking about what are alternatives that are non-opioid for pain management, because we certainly have a lot of people with pain, chronic pain, difficult to treat. And really our focus was, how do you do that in Medicaid? What are state options for Medicaid, and where are states really moving towards? And I would say there is a lot of interest in thinking about, you know, acupuncture, massage therapy combined with cognitive behavioral therapy, thinking about the nutrition element of that and how that all links together. It's a harder thing to package in terms of a Medicaid benefit, and I do think some states have been concerned about, how do we figure out what conditions, you know, what do we authorize massage therapy and acupuncture therapy for? Is it low back pain? Is it for these other modalities? Because in the Medicaid program, of course, once you authorize a benefit, lots of people can get it. So if you're interested, we have a paper coming out probably in a month or 2 on this. So highlight that for you.
So I want to thank our panelists for the great presentation, and to all of you for your great questions.
Thank you. Thank you all. I know the senator is on a very tight schedule, so I will not do justice to him with this very, very quick introduction. I've had the pleasure of knowing Senator Portman since he was Representative Portman, first elected to the House of Representatives in 1993, later to become U.S. Trade Representative and OMB Director in George W. Bush administration, and then first elected to the Senate in 2010. He clearly is a stalwart in the battle to combat addiction. He began his first fight, as I recall, even when he was in the House of Representatives, and certainly continues that fight today. We know the opioid epidemic has significantly directly impacted his state, as we just heard from Liz, and we very much appreciate, Senator, you taking the time and willingness to traipse down here to spend a few minutes with us to share your thoughts on where we stand in this battle and where it's going. So thank you, Senator.
Bill, thank you. Yeah, I've known Hoagland for too long. But in 1993, I was elected to the House, and I remember I was told that a constituent was coming and wanted to visit with me. And it was a situation I knew about because it had happened in my congressional district, but a young man had died of an overdose of huffing gasoline and smoking dope at the same time. And his mom wanted to come and present me a gold bracelet. So I, of course, had the meeting with her, and also she met with President Bill Clinton, much more fun for her, and interesting because it was part of the National CADCA conference that year, and he also got a gold ID bracelet. I still have mine. And I was ready for her. I said, you know, we spend $15 billion a year on interdicting drugs and prosecuting criminals in the war on drugs, and you know, your tax dollars are being used to fight against this scourge. And she said, how does that help me? You know, and I was kind of left without any good answer. She said, you know, I went to the school where my son is, my son's brother is still going to school, and the younger brother was with her, and they're in denial. It doesn't happen here. It's not our fault. I went to my church, and they said, you know, we really aren't in a position to talk about this issue. In other words, we don't want other people to know that we have a drug problem here at the church. And I called a meeting of the neighbors, and nobody showed up. And at the same time, I was learning a lot more about this issue, and this is back in the 90s. You may remember in the 1980s, there was a big push. We'd kind of taken our eye off the ball, and suddenly cocaine, marijuana, other drugs were becoming much more prevalent, particularly among young people. And that combination of hearing more about its impacts on everything from crime to economic development led me to author the Drug-Free Communities Act, which has ended up, by the way, helping to spawn 2,000 community coalitions around the country. I started my own community coalition back then in 1994, and still very involved with it. I've chaired it for 9 years. You know, I've seen this thing go up and down, and sadly, in the 2000s, none of us were as cognizant as we should have been of the dangers of opioids. I remember hearing about, in Kentucky, I'm from Cincinnati, so right across the river, there was this drug that was, you know, causing some issues, and this company, Purdue Pharma, was producing it, and but we really didn't understand the significance of it and what would happen and how it would spread. And, you know, for those of you who've read Sam Quinones's book about Portsmouth, Ohio, and the pill mills, it hit us hard in Ohio, West Virginia, Kentucky before us. But the point is, we cannot take our eye off the ball again. You know, we did it in the early 1990s. We did it in the 2000s with regard to not understanding the importance of the opioid epidemic that was coming, and the now 70,000 Americans who lose their lives every year to overdoses. And I think we have to be sure that this doesn't happen again. Therefore, I love the Bipartisan Policy Center's report, both because it talks about what's actually going on in my state. I'm one of the 5 states. Thank you, Hoagland, or whoever decided to pick Ohio. I know the West Virginians aren't very happy with you, but I'm happy that you picked Ohio, because we need the data badly. We need to tell people what's going on. But I also like the fact that you talk about sustainability in your report, as well as flexibility and coordination. And I've given now, I think, 42 speeches on the Senate floor. My colleagues are really tired of hearing from me on this issue, on the drug crisis, not just the opioid crisis, because it's not just about opioids. It's about an addiction mentality. It's about our country's culture. And I've made the point recently in a couple of floor speeches that we're making progress, and we are. And the report indicates that. Significantly, we now know that from the National Center for Health Statistics at CDC, that we have, for the first time in 8 years, a reduction in overdose deaths, which is, you know, the best way to measure, because it's the only measurement we really have, because the coroners provide us that information every year. And by the way, I get a monthly readout from Ohio. But this slight downturn, it's less than 1% nationally. By the way, in Ohio, you know, our level was so high, and we've done, I think, so many innovative, important things that for the first time in 8 years, we're not just seeing a drop, but we're seeing a 21.4% drop in overdose deaths in the first half of 2018. That's based on what we hear from, again, CDC, the Center for Health Statistics, the biggest drop in the country. We're proud of that. But it's from such a high watermark. But my concern that I've talked about with my colleagues is, as we're making progress, let's not back off. We need to sustain this effort. And again, I'm delighted to see, for the first time in 8 years, fewer people dying of overdoses. What the Bipartisan Policy Center has done with this study is give us some more detail about that and some sense of what's working, what's not working. And we need that information badly. Over the last few years, what Congress has done is pretty remarkable. Just as in the 1990s, we kind of, not just the Drug-Free Communities Act, we passed the Drug-Free Media Campaign, the Drug-Free Workplace Act. I was very involved back then. But in the last 3 years, you think about it, Congress has passed the Comprehensive Addiction Recovery Act, which I co-authored with Sheldon Whitehouse. So it's been totally nonpartisan, not just bipartisan, but also the cures legislation, 21st century cures legislation. Those two combined added, over the last few years, $3 billion plus of taxpayer dollars to this effort. That's significant. It's historic. I think as historic is the fact that we not only put unprecedented amounts of money against it, but we, in the process, acknowledge that addiction is a disease and sort of change the paradigm and focus not on as much on the interdiction I talked about and eradication of crops in other countries or even the law enforcement side, but instead on the issues of prevention and treatment and longer-term recovery. And yes, supplying Narcan to our first responders, which is one reason we see these better numbers, all those things combined. So I think it's important we recognize that we have made some progress, because that's important to let taxpayers know this money has not been wasted, right? We're not just throwing the money at the problem and hoping it'll go away. We're doing this based on evidence. We spent 3 years studying this issue before we came out with the Comprehensive Addiction Recovery Act. We had 5 conferences here in Washington. We brought experts in from all over the country, including some of you. And I'm really fortunate that in Ohio we have people like Liz who are experts, and were experts even before the rest of the country acknowledged this epidemic. So we wrote a good bill in terms of saying, let's send this money out for innovative purposes to close gaps. I've gone around the state of Ohio, and as you talk about in your report, we've got a lot of great things going on. I have gone to more than a dozen site visits just on the CARA legislation, my legislation, where I've said how we're using this money. And then I come back and I report to my colleagues, including these floor speeches. And one of the main purposes is to say, how do you deal with not just providing more Narcan, which our legislation does, and that's important, but then getting someone into treatment. The most frustrating thing for a first responder is to administer Narcan time and time again to the same person, sometimes in the space of a week, sometimes in the space of a day. And so now you've got these rapid response teams that are growing all over our state, funded by Comprehensive Addiction Recovery Act, that are actually sending a social worker and a treatment expert and a law enforcement official to the home, hopefully as soon after the Narcan is applied or the person leaves an emergency room, if they go to an emergency room, as possible. Sometimes it's a matter of hours when the resources aren't there. Sometimes it's a matter of days. But getting there, and amazing success rates of getting people into treatment. It was virtually zero before, by the way. If you talk to the emergency rooms and they're honest with you, partly because of HIPAA regulations, they don't really know, but they will say very few people are actually getting into treatment who come to them. And people are refusing to go to emergency rooms too, so they never even end up in the healthcare system. But at a minimum, we've got to figure out how to close that gap and to give people the option to get into treatment. There's a program in Cleveland that's working well through Metro Health that tells me they now have an 80% success rate. That is remarkable. I'm not saying it's true everywhere, but that 80% of the people who get a knock on the door end up saying, okay, I'm ready, I'll do it. I just went through, an experience where I saw my life flash before my eyes, and you hope that would be a time to get people into treatment. What the success rate is in the treatment program is another question. Too many of our treatment programs are several weeks, and then the person's out the door without any follow-up or any opportunity to get into a longer-term recovery program. One thing we studied was how do you get more money into recovery? Congress had never funded recovery before the CARE legislation. That's another gap. Again, great programs in Ohio that I've visited that are providing not just the ability to get the longer-term recovery, but housing, which is one of the big issues, obviously. If you go back to the same place you were before with the same people, you're likely to continue to use. So we're not there yet. I wish some of these smart people who are on the panel here would tell us the answer, how you get better and more effective treatment, because it's frustrating, it's costly. Of the few thousand people I've met who are recovering addicts or addicts, most of them have been in treatment many times. Some a few times, some many times, like 9, 10 times. And that's not the answer. We've got to figure out how to understand what works in treatment. I have some ideas on that. The legislation supports programs that, again, have this longer-term tail, the recovery part of it, which I think is really key to longer-term success. I think faith plays a big role for a lot of people. I know it does in Ohio. I think a job plays a big role. So the job training mixed in with recovery is so important, because ultimately it's about meaning, right? It's about purpose in life. It's about giving someone the ability to feel like they are making a difference. It's a complicated issue, because some people became addicted because they had a wisdom teeth extracted, and the wisdom tooth was taken out, and then a dentist shoved across the counter 60 pills and said, "These will make you feel better." I mean, give me a break. There should be no opioids used in that situation. And you can imagine, we had some interesting talks with the American Dental Association. They've got a new president now who seems committed to this, but that person who becomes addicted because a doctor has told them these pills are what you should take is very different than the person perhaps who makes a choice to become someone who gets involved in the drug culture because of that lack of purpose or meaning or emptiness in life. It's both, and it's out there. And no one can tell you what the percentage is, by the way, because I've asked everybody, including all these experts here. But significantly, if you can find that meaning, that purpose in life as part of recovery, I think it makes a big difference. And the numbers are overwhelming in terms of the folks who are outside of our workforce right now who are addicted to opioids. The Brookings study by Alan Kruger, who just passed away, unfortunately, and the Department of Labor study shows that almost half of the men in America, of the roughly 8 million men who aren't even showing up to try to get a job, we have a very high labor force, lack of labor force participation today. It goes back to 1978 in the numbers last month, before you can find this low a level of labor force participation. Almost half of those men acknowledge taking prescription pain medication on a daily basis. I mean, it affects everything, doesn't it? Anyway, we are making progress. I'm happy about that. I've also gone to about a dozen sites to talk about cures, that legislation, how it's working. And again, it's remarkable what's being done, mostly through our Adamus boards, because it comes to the state, as you know, and then is devolved down to the county level to our alcohol, drug, mental health boards. And I think they're doing a very good job with that funding. We've gotten $26 million the last 2 years in Ohio. We need it. We appreciate it. I will also say that something that is positive about what Congress has done is, you know, the best is yet to come on a couple of things. Well, one is trying to keep the cost of fentanyl higher so that it's not so pervasive and causing so much heartbreak and devastation in our country and in my state of Ohio in particular. If you look at the numbers, fentanyl is by far the biggest killer. My strong view is that we wouldn't be here in 2019 talking about finally making progress. We would have been talking about it 2 or 3 years ago, but for fentanyl, because it overwhelmed the system. I know that's true in Ohio. Just as we were beginning to make progress on heroin and prescription drugs, then fentanyl came in, and it created an incredibly inexpensive, incredibly powerful drug, 50 times more powerful than heroin on average. And so over deaths in Ohio, 2/3 of them are from fentanyl, even today. Some mixed with cocaine, as you know, which is causing a whole other issue, and some even mixed with crystal meth. So the STOP Act and the Interdict Act working together will make a difference there, because this stuff's coming in mostly from China, mostly by the mail system, despite what you might hear. That's where it's coming from. And I've talked to a lot of experts about this, and we've got to deal with it, and we finally are. The post office pushed back, as you know, for several years on this, resisted. We finally got the legislation passed. It's done. It's being implemented as we talk, and it'll make a difference. And again, at a minimum, raising the cost, reducing supply, stopping some of this poison from just coming right into your post office box. And the other one is the IMD exclusion. That's not in place yet, but it's being implemented as we talk. And this is very simple. I mean, believe it or not, we had a policy in place really since the 60s saying for Medicaid reimbursement, which is the key to many people in Ohio to getting into treatment, if you had a treatment center that was otherwise working great, you were limited to 16 beds. That 17th bed, you did not get your Medicaid reimbursement. That's crazy. It's an arbitrary deadline, right? So finally, we're making progress there because we did pass legislation at the end of the year saying we're going to take off that cap. Now, it's only for 5 years, so stay on that, please, if you believe, as I do, that that's bad policy. But that'll make a big difference in terms of opening up treatment options in Ohio. I'm tired of talking to parents who say, yeah, my kid was ready, but there was no room at the inn. You know, I do these teletown halls every month, and I always ask the opioid question, and more than half the people on the call, and every call I've done in the last several years has said we're affected by this issue, personally, directly. Some places in Southeast Ohio, as high as 68% of the people on the call. Not self-selected. These are just 25,000 people who call in on some issue. But a guy tells me the story that, you know, his daughter went, she was finally ready for treatment, and there was a 3-week wait. And so she came home. And 4 days later, she was found in her bedroom, having overdosed and died. So these treatment access issues are real. And this will help, because why should a treatment center that's doing good work be told you're limited to 16 beds? So that's coming. And those initiatives will help to continue for us to make progress to the point of sustainability. But we need to do more. CARE 2.0 has now been introduced. We don't have it passed yet, but it has a number of new initiatives, including, by the way, a 3-day limit on prescription pain medication for acute pain. The American Medical Association is not there yet. If you agree with me that 3 days is enough, I hope you'll help us to get that legislation passed. They're not the only group that's not wild about that legislation, but I think it's totally consistent with the science. And the 2 groups I will point you to is CDC, which has said after that 3rd day, the chances of addiction rise considerably, after the 4th even more, the 6th even more. But second is the FDA that says after 3 days, you know what, other pain medication is just as effective for most people. So I heard you talking a little, as I came in, about alternatives. Pain can be dealt with in a number of different ways, but even if it's just ibuprofens or Toradol, you know, after that 3rd day, the need for an opioid is diminished considerably. This is not based on what I'm saying. This is good science. So I hope we'll look at this as a country and say, why are we allowing these doctors to prescribe for acute pain, not chronic pain, not cancer, but for acute pain, to make these 60-pill deliveries in a doctor's office and telling a patient, you ought to take this? It makes no sense. And we're going to continue to have people become addicted inadvertently unless we do something about these accidents and injuries. So that's part of what's in CARE 2.0. Sustainability, we can't take our eye off the ball. We talked about that. Greater federal coordination, absolutely. ONDCP, by the way, the Office of National Drug Control Policy, in my view, ought to play a more central role in coordinating. That's their job. I'm concerned about the budget cuts that are being proposed in the President's budget. We'll fight those again. Greater federal coordination, Regina LaBelle can tell you, because she was Chief of Staff at ONDCP, is needed. And one thing I hope that will happen is there will be a national prevention program initiated. It was authorized in CARA, Comprehensive Addiction Recovery Act, and it's yet to be implemented. That's something I think would be part of that federal coordination. Uniquely can be done at the federal level. And by the way, let's leverage private dollars into that. Let's tell the private sector, including the pharmaceutical companies, how would you like to be partners in this? And use that federal money to actually leverage more, which has been authorized already, to leverage more private sector money and really have a national campaign that can make a difference. And finally, flexibility for federal funds. Last week, I was in Ohio, again, meeting with people who are on the front lines, and what I heard is what I've been hearing the last few months in Ohio, which is, thank you for your help on the opioid crisis. We're making progress. Guess what? Crystal meth has come back with a vengeance. And it's not the meth that was made in somebody's trailer or in a basement. And by the way, that's virtually not happening in Ohio anymore. You know why? Because the pure crystal meth from Mexico is so much more powerful and so much less expensive. Why would you make it in your basement? So that's better from an environmental point of view, perhaps, but it's devastating because the impact of it is so devastating. A law enforcement official in Columbus, Ohio told me that it's less expensive to buy crystal meth on the streets of Columbus by volume than it is to buy marijuana. So it's not just about opioids. It's a broader issue about addiction, and that's why more flexibility is needed. Did we do the right thing by focusing on opioids? I think we did. I think we needed the tourniquet. It had to be applied. But I think now is the time for us to broaden that, not take our eye off the ball, ensure we have better federal coordination, state and local, nonprofit, and ensure that we are indeed doing everything we can to keep the focus on this issue so that we can continue to see more Americans reach their God-given purpose, whatever it is. I know it's not to be an addict. I know it's to be someone who can fulfill his or her dreams, can be a productive member of society, and we're making progress, but much more to go. Thank you all.
Thank you, Senator, and thank you for being a leader in this battle going forward. I want to thank Liz and Hemi and Patrick and Regina, and again, a special thanks to the BPC staff that spent a lot of time on this, Dr. Anand Parak, Tim Swope, Morgan Bailey, Caprice Caparo, and Joanne Donaldson. Also, I want to give a shout out and appreciation to the Arnold Ventures for their support in doing this work. And certainly thank you, all of you, for sticking in here with us this morning and this afternoon on this important topic. I think just one last comment. Let us all hope for the day when we don't need to fund these types of programs because we've won the battle. But until then, let us work in a bipartisan manner to maintain and sustain the funding needed as the battle goes on. Thank you very much for today. Thank you.